Good afternoon. This is House Appropriations Committee. It is Thursday, May 15th, 2025. It is just after 2:30. It's just 2:30 in the afternoon, and we are back to talk about healthcare, S-126. So we have Jen Carby from Legislative Council, Nolan Langwell from Joint Fiscal Office, and some leadership from the House Healthcare Committee, and we will hear all this. And as I said before we went live, we will do everything today, but we will not be voting on the bill today. Very possibly tomorrow, but not today. Okay. So.
Good afternoon, Jen Carby from the Office of Legislative Counsel. We are looking at S-126, an act relating to healthcare payment and delivery system reform. And I can put the language up on the screen. Madam Chair, how much detail do you want?
The more detail you give us, the more everybody gets into the weeds. So we are not the healthcare committee, fairly high level. And then I'm sure there'll be questions. So it's a matter of steering the ship at the right level here.
Okay. I'll try to hit that right note. It might be helpful as we start. So this is a strike all amendment from the House Healthcare Committee.
We have as passed the Senate and the Healthcare Committee report. So you want the Healthcare Committee report?
Healthcare Committee report, yeah.
You need this as passed the Senate for any reason? No.
No, unless you're just interested in what's in it.
Oh, spare time can read that. Okay.
Yes. A lot of similarities and a fair number of differences.
Okay, great.
So we start out with the purpose of the act and the goals. So I think we will look in more detail here at the purpose and the goals just to kind of frame the bill for you. So the purpose is to achieve transformation of and structural changes to Vermont's healthcare system. And enacting this legislation, it says the General Assembly intends to advance the following goals: improvements in health outcomes, population health, quality of care, and regional access to services, an integrated system of care with robust care coordination and increased investments in primary care, home health care, and long-term care, stabilizing healthcare providers, controlling the costs of commercial health insurance, and managing hospital costs based on the total cost of care, beginning with reference-based pricing, which we'll see more about, evaluating progress in achieving system transformation and structural changes by creating and applying standardized accountability metrics, and establishing a healthcare system that will attract and retain high-quality healthcare professionals to practice in Vermont and that supports, develops, and preserves the dignity of Vermont's healthcare workforce. Those are the purpose and the goals. The act I've separated with some reader assistance headings. So this next group of sections deals with hospital budgets and payment reform. Section 2 amends a statute setting out the Green Mountain Care Board's duties to add some references to reference-based pricing, which you're going to see in more detail in a future section. So that's really all that is happening. And here are some references to reference-based pricing. Section 3 is where we're going to look at reference-based pricing. This amends an existing statute in the Green Mountain Care Board chapter that allows the board to do some rate setting, set rates that healthcare professionals will accept for their services. To date, they have not really used this authority, but in setting up specifically reference-based pricing, which actually starts on page 6 or bottom of page 5, this is going to operationalize a piece of that. So for the most part, other than subsection headings, I did not make any changes in the existing statute except to strike out a particular reference in this description of what is encouraged in the board's payment methodologies that it approves access to primary care health services. And under existing law, that specifies for underserved individuals, populations, and areas. And the House Healthcare Committee felt that was a little outdated to just limit to those. So even though we weren't otherwise amending this piece of it, they struck that language.
Okay, we have a question.
Reference-based
We
pricing.
are getting there. I'll tell you what it is.
Because I read through it before, I didn't see a definition. Is there one?
It is not specifically defined. It's more about how it works. So just in general, the idea of reference-based pricing is to set prices based on a percentage of a known quantity. So in this case, often reference-based pricing is based on a percentage of the Medicare payment for that item or service.
So the reference refers to that?
The reference refers to what it means, what it, yes, what
So
What's the
my question
correction
is,
system?
what are we referring to?
right.
If it's
So let's look at the description of how it works, and that may help. So this new subsection on reference-based pricing directs the Green Mountain Care Board to establish reference-based prices that represent the maximum amounts that hospitals will accept as payment in full for items provided and services delivered in Vermont. This is, again, sort of a global concept, and we get into more of the details as it goes through. So the first part, and the part that will be implemented fairly soon, is for hospitals, and it's setting the maximum amounts that hospitals will accept as payment in full. So we're not telling the payers what to pay, we're telling the providers what they can accept. And this should allow us to set prices more broadly across the system, potentially even for payers over whom we do not have regulatory authority.
Just to pause for a second. So Wayne, our auditor has done a couple of reports on reference-based pricing, which you can find somewhere, probably on the healthcare website too. Yeah. Okay, on Nolan's fiscal note, there's a link to it. And so you can see that the difference in prices across the state, you go to get a colonoscopy one place and it's 1,200 and another place it's 5,000. I'm making those numbers up, but there's,
Right.
I think it's to bring in.
Right. So if Medicare, whatever rate Medicare pays, there would be a percentage of that, typically more than Medicare. Medicare is deemed roughly, although probably a little under cost, but to be approximately reimbursing for costs. So
I was curious why the term accept was instead of charge.
because the hospitals charge a lot, but that's not actually what gets paid. So the payments are typically a negotiated rate that is a percentage of the charge. So just setting what they charge doesn't really give regulatory control over what is getting paid.
Thanks.
So board shall establish reference-based prices for hospitals. The board may also implement reference-based pricing for services delivered outside a hospital. And in this case, we would be looking potentially at the minimum amounts that would be paid for the items provided and services delivered. And again, you'll see some more about this going forward, but some of the idea behind that is to try to increase the reimbursement rates, for example, to primary care providers that health insurance might pay for primary care services, to incentivize that type of care and that type of treatment, assuming that that is the right care in the right place at the right time for the individual patient. It directs the board to consult with health insurers, hospitals, other healthcare professionals as applicable, the Office of the Healthcare Advocate, and the Agency of Human Services in developing reference-based prices pursuant to this subsection, including on ways to achieve all payer alignment on the design and implementation of reference-based pricing. It requires the board to implement reference-based pricing in a manner that does not allow healthcare professionals to charge or collect from patients or health insurers any amount in excess of the reference-based amount established by the board. So this, if you've heard of balance billing, this says no balance billing. So the hospital can't say, well, that's fine, we'll only accept $100 from the insurance, but then we'll bill the patient for another 75, and now we're getting 175. This says you can't do. Reference-based prices established pursuant to this subsection, so here's where we get to more of the methodology, shall be based on a percentage of the Medicare reimbursement for the same or a similar item or service, or on another benchmark as appropriate, provided that if the board establishes prices that are referenced to Medicare, the board may opt to update the prices in the future based on a reasonable rate of growth that is separate from Medicare rates, such as the Medicare Economic Index measure of inflation, in order to provide predictability and consistency for healthcare professionals and payers, and protect against federal funding pressures that may impact Medicare rates in an unpredictable manner. So basically, the idea here is if you're going to use Medicare at some point in time, that's fine, but maybe don't peg the rates just to Medicare if there are federal financial pressures that affect how much funding the federal government is putting into Medicare that then has an impact on those rates in a way that may not make sense for healthcare delivery in Vermont. It also specifically allows the board to reference to and update based on other payment or pricing systems where appropriate. It directs the board to consider a number of things when it's establishing reference-based prices for a hospital, including considering the composition of the community served by the hospital, including the health of the population, demographic characteristics, acuity, payer mix, labor costs, social risk factors, and other factors that may affect the cost of providing care in the hospital service area, as well as the hospital's role in Vermont's healthcare system. As far as timing, the board must begin implementing reference-based pricing as soon as practicable, but not later than hospital fiscal year 2027. So that starts in October of 2026 and runs through September of 2027. By establishing the maximum amounts that Vermont hospitals shall accept as payment in full for items provided and services delivered. And after initial implementation, it directs the board to review the reference-based prices for each hospital annually as part of their hospital budget review process. Requires the board, in collaboration with the Department of Financial Regulation, to monitor implementation of reference-based pricing to ensure that any decreases in amounts paid to hospitals also result in decreases in health insurance premiums, and requires the board to post its findings about alignment between price decreases and premium decreases annually on its website. The board must identify factors that would require terminating or modifying the use of reference-based pricing in one or more hospitals. Subdivision 5 allows the board, in consultation with the Agency of Human Services and the Comprehensive Primary Healthcare Steering Committee that you'll see later in the bill, to implement reference-based pricing for services delivered outside hospital, such as primary care services, and to increase or decrease the percentage of Medicare or another benchmark as appropriate. First, to enhance access to primary care, and later for alignment with the statewide healthcare delivery strategic plan that you also see later in the bill once it's established. And the board may consider establishing reference-based pricing for these services by setting minimum amounts that will be paid in order to prioritize access to high-quality healthcare services in settings that are appropriate to patients' needs in order to contain costs and improve outcomes. And then it specifies that the board's authority around reference-based pricing does not include the ability to set amounts for Medicare or Medicaid, recognizing we don't have authority over Medicare, and Medicaid is already being handled in this manner by the Agency of Human Services. So that is the end of reference-based pricing. Ready to move on to hospitals and hospital budgets. Section 3A adds a new definition in the hospital budget review subchapter entitled 18 in chapter 2.1 for hospital network. And that is a system comprising 2 or more affiliated hospitals and may include other healthcare professionals and facilities that derives 50% or more of its operating revenue at the consolidated network level from Vermont hospitals, and in which the affiliated hospitals deliver healthcare services in a coordinated manner using an integrated financial and governance structure. We have one hospital network in Vermont, the University of Vermont Health Network, as many of you are probably familiar with that.
Which is not to be confused with UVM Medical Center.
UVM Medical Center is an individual hospital
Right.
that is affiliated with the UVM Health Network, but is,
I think people get
Yes.
confused about that.
that is very true.
Clarify that on camera.
Yes. All right, section 4 amends the hospital's duties with respect to their hospital budget review by the board by directing them to submit information as directed by the board, so we can try to maximize standardization and allow the board to make more direct comparisons of expenses across the healthcare system. Sort of looking at apples and apples for hospital budgets. Section 5 makes some changes to the hospital budget review process and what the board must do, including adding references to considering the statewide healthcare delivery strategic plan. Again, you'll see that coming up in section 8, and consulting with the Agency of Human Services. A lot of renumbering. New number 6 for a hospital that operates within a hospital network. It directs the board to review the hospital network's financial operations as they relate to the budget of the individual hospital. And you'll see more about hospital networks in the next section as well. In new number 15, directs the board to consider the salaries for the hospital's executive and clinical leadership. This is existing law, but this adds including variable payments and incentive plans. Also directs the board to compare the base salaries and total compensation for the hospital's executive and clinical leadership with those of the hospital's lowest paid direct care workers. And it directs the board to consider the number of employees at the hospital whose duties are primarily administrative in nature compared with those who are providing direct services. In amended subsection C, individual hospital budgets that the board establishes must first, again, adding a reference to the statewide healthcare delivery strategic plan once established, including total cost of care targets. Second, reflect the reference-based prices established by the board that we looked at in the process we looked at previously. Number 4, promote, existing law says promote efficient and economic operation of a hospital, and this adds, and if a hospital is affiliated with a hospital network, ensure the hospital's spending on the hospital network's operations is consistent with the principles for healthcare reform. These are sometimes called the Act 48 principles that are codified in 18 VSA 9371 and the statewide healthcare delivery strategic plan once established. And then adds a new number 8, that the budgets include meaningful variable payments and incentive plans. This is how they're paying their employees and leadership that are, again, consistent with this section and the Act 48 principles, or the principles in section 9371. Subsection E directs the board to consult with the Vermont Program for Quality in Healthcare to come up with ways to measure hospital costs, quality, and access, and alignment with the statewide healthcare delivery strategic plan. The next few subdivisions here in subdivision 2 creates what people have been sometimes referring to as a reverse CON process, reverse certificate of need. This would require that a hospital that is proposing to reduce or eliminate any service in order to comply with its budget ordered by the Green Mountain Care Board must provide notice of intent to the board, the Agency of Human Services, the Office of the Healthcare Advocate, and the members of the General Assembly who represent the hospital service area not less than 45 days prior to the proposed reduction or elimination. So this is providing notice before reducing or eliminating a service to comply with the budget order. The notice must explain the rationale for the proposed reduction or elimination and describe how it is consistent with the statewide healthcare delivery strategic plan and the hospital's most recent community health needs assessment. It allows the Green Mountain Care Board to evaluate the proposed reduction or elimination for consistency with the plan and the community health needs assessment, and to modify the hospital's budget or take such additional actions as the board deems appropriate to preserve access to necessary services. Subdivision D says if there's a service that has been identified for reduction or elimination as part of the transformation efforts undertaken by the board and the Agency of Human Services under Act 167 of 2022, then it's already part of a state approved process and it doesn't need to go through that notification process. And again, here, the board, in collaboration with the Department of Financial Regulation, will be monitoring implementation of any authorized decrease in services to determine its benefits to Vermonters or the healthcare system or both. That is the end of hospital budgets. Then we get into the hospital networks, some regulation there. Section 6 adds a new section in the hospital budget review subchapter, directing or allowing the board to review and evaluate the structure of a hospital network to determine whether any network operations should be organized and operated out of a hospital instead of through the network, and whether the existence and operation of a network provides value to Vermonters, is in the public interest, and is consistent with the Act 48 principles and the statewide healthcare delivery strategic plan. In order to protect the public interest, it allows the board on its own initiative to investigate the financial operations of a hospital network, including compensation of the network's employees and executive leadership, and allows the board to recommend any action it deems necessary to correct any aspect of the structure of a hospital network or its financial operations that are inconsistent with the Act 48 principles or the plan once established. Then we look at healthcare contracts. Section 7 adds some language to an existing statute about contracts between payers and providers to require that upon request, a contracting entity, so that's a health insurer or somebody working on behalf of an insurer or pharmacy benefit manager. So upon request, a contracting entity or provider must provide an unredacted copy of an executed or proposed healthcare contract, TFR, or the Green Mountain Care Board, or both. So would allow some insight into the agreements or proposed agreements between payers and providers. Now we get to the statewide healthcare delivery strategic plan. And I don't know how much detail you want on this. This section directs the Agency of Human Services in collaboration with a number of stakeholders to lead development of an integrated statewide healthcare delivery strategic plan that will do a number of things. First, align with the Act 48 principles, identify existing services and promote universal access across the state to high quality, cost effective healthcare services, a lot of different types of services listed. Define a shared vision and shared goals and objectives for improving access, quality, efficiency, and affordability, including benchmarks for evaluating progress. Identify the resources, infrastructure, and support needed to achieve established targets to ensure feasibility and sustainability of implementation. Provide a phased implementation timeline with milestones and regular reporting that can adapt as needs evolve. Promote accountability and continuous quality improvement across the healthcare system by using data, scientifically grounded methods, and high quality performance metrics to evaluate effectiveness and inform decision-making. Provide annual targets for the total cost of care across the healthcare system. And using those targets, the plan would identify appropriate allocations of healthcare resources and services across the state that balance quality, access, and cost containment. Would also establish targets for the percentages of overall healthcare spending that should reflect spending on primary care services, including mental health services, and on preventive care services. And those targets should be aligned with the total cost of care targets. It would build on data and information from a number of existing efforts around transformation planning from Act 167, existing reports and plans that are developed pursuant to statute, looking at the hospital community needs assessment, quality information, the Vermont Program for Quality in Healthcare statewide quality assurance program, certain past reports looking at proportion of healthcare spending allocated to primary care and payments to patient-centered medical homes, and then anything else they deem appropriate. The plan will identify opportunities to improve quality of care, identify gaps in access, as well as unnecessary duplication of services, identify opportunities to reduce administrative burdens, identify barriers to achieving the plan's goals, and to the extent feasible, how they could be removed or mitigated, priorities for steps in achieving the goals of the plan, barriers to adequate mental health and substance use disorder services, opportunities to integrate healthcare services for individuals in the custody of the Department of Corrections as part of Vermont's healthcare delivery system, enhancements in quality reporting and data collection, and systems to ensure the reported data is shared with and accessible to the healthcare providers who are providing care so they can track performance and inform improvement. Requires the agency to provide the plan to the House Healthcare Committee, House Human Services Committee, and Senate Health and Welfare by January 15th, 2027, and to update the plan every 2 years and provide it to the General Assembly by December 1st of every other year, beginning December 1st, 2029. That's the middle year in a biennium, so that the legislature that is coming back in January will have access to that information.
And did we already talk about the timing of when, I mean, some of this, when reference-based pricing goes into effect, because it's not going to be like July 1st. It's going to take some time. We already talked about that.
Reference-based pricing, the language says as soon as practicable, but not later than hospital fiscal year 2027.
Okay, so the point is they have some time.
Yes.
Next year, before.
Yeah, okay. Great, thank you.
All right. Section 9 establishes the Healthcare Delivery Advisory Committee to establish healthcare affordability benchmarks, evaluate and monitor the performance of Vermont's healthcare system and its impact on population health outcomes, collaborate on the statewide healthcare delivery strategic plan, advise the Green Mountain Care Board on the design and implementation of an ongoing evaluation process to continuously monitor current performance in the healthcare delivery system, and to provide coordinated and consensus recommendations to the General Assembly on issues related to healthcare delivery and population health. There are 19 members on this committee, which I will take you through if you want, or just tell you there are 19 members. We'll just skip to the end where you'll be happy to see that they do not receive per diem compensation or reimbursement of expenses for their participation on the advisory committee. So there's no fiscal note for that case.
Okay.
Section 9A establishes the Comprehensive Primary Healthcare Steering Committee. That steering committee is created to inform the work of state government as it relates to access to, delivery of, and payment for primary care services in Vermont. This one also has a number of members, 16. Spoiler alert, they also do not get per diems or reimbursement of expenses, so that you can consider this as a non-expense committee. Directs the steering committee to engage in an ongoing assessment of comprehensive primary care needs in Vermont, provide recommendations for recruiting and retaining high-quality primary care providers, develop proposals for sustainable payment models for primary care, identify methods to enhance Vermonters' access to primary care, recommend opportunities for reducing administrative burdens on primary care providers, recommend mechanisms for measuring the quality of primary care in Vermont, provide input into the statewide healthcare delivery strategic plan, consult with the Green Mountain Care Board if the board develops reference-based pricing for primary care providers, and offer additional recommendations and guidance to the Blueprint for Health, Office of Healthcare Reform, and the Agency of Human Services, General Assembly, and others on ways to increase access to primary care and improve patient and provider satisfaction. It's got some implementation provisions, and again, no per diem or reimbursement. Section 10, we get into a couple sections on data integration and data sharing. Section 10 directs the Agency of Human Services to collaborate with the existing Health Information Exchange Steering Committee to evaluate the potential to develop an integrated statewide system of clinical and claims data. It requires the analysis to address the feasibility of developing such an integrated system, potential uses for a system, whether and to what extent the system would improve patient, provider, and payer access to relevant information, reduce administrative burdens, increase access to and quality of healthcare for Vermonters, and reduce costs, and if so, how to measure that. Appropriate privacy and security safeguards for an integrated system, and any additional considerations they deem appropriate. The agency would report by January 15th, 2026 with its findings and recommendations. And in addition to all of those items in subsection A, have the agency explain the advantages and disadvantages of developing such a system, the agency's recommendation about whether the state should pursue it, and describe the value, if any, that it would bring to the system. And it specifies that the agency shall not begin to implement an integrated statewide system of clinical and claims data unless and until directed to do so by legislative action. Section 11 relates to the Green Mountain Care Board, and specifically what they can do with information they receive pursuant to subpoena. It allows the board to share any information, papers, or records it receives under a subpoena or notice to produce, just what the rest of this subsection deals with the Agency of Human Services or Department of Financial Regulation, or both, as appropriate to the work of the agency or department, as long as the agency, department, or department agrees to maintain the confidentiality of anything that is exempt from the Public Records Act. The next few sections are entitled Healthcare Reforms Addressing Exigent Needs. This is so some of what we're looking at is kind of longer term, but you all know the healthcare system is experiencing a lot of challenges right in this moment. So section 11A directs the Agency of Human Services to facilitate collaboration and coordination among healthcare providers to encourage cooperation in developing rapid responses to the urgent financial pressures facing the system and identify opportunities to increase efficiency, improve quality, reduce spending on prescription drugs, and increase access to essential services, while reducing hospital spending for hospital fiscal year 2026 by not less than 2.5%. It requires the agency to facilitate and supervise the participation of hospitals and other providers as necessary to be afforded state action immunity under federal and state antitrust laws. And it requires the agency to report on the proposed reductions that it approves pursuant to this section, including applicable timing and appropriate accountability measures, to the Health Reform Oversight Committee and the Joint Fiscal Committee on or before July 1st, 2025. And on or before the first day of each month of hospital fiscal year 2026, which does begin on October 1st, 2025, the agency would provide updates to the Health Reform Oversight Committee and Joint Fiscal Committee when the legislature is not in session, and to House Healthcare and Senate Health and Welfare when it is, on their progress in implementing and achieving the hospital spending reductions identified pursuant to this section. Section 11B requires the agency to identify specific outcome measures for determining whether, when, and to what extent each of these specific goals that were in Act 167 of 2022 has been met. So the goals set out in that provision are to reduce inefficiencies, lower costs, improve health outcomes, reduce health inequities, and increase access to essential services. By July 1st, 2025, it would have the agency report to, again, Health Reform Oversight and Joint Fiscal Committees with the specific outcome measures developed pursuant to subsection A and a timeline for accomplishing them, how the agency will determine its progress in accomplishing the outcome measures and achieving the transformation goals, including how it will determine the amount of savings attributable to each inefficiency reduced, and how it will evaluate increased access, the impact that each transformation decision made by an individual hospital has or will have on the healthcare system, including on costs and health insurance premiums, how the agency is tracking and coordinating the transformation efforts of individual hospitals, make sure that they are complementary of the efforts of other hospitals and will contribute in a positive way to a transformed healthcare system. The amount of state funds and federal funds, if applicable, that the agency has spent on Act 167 transformation efforts to date or has obligated for those purposes, and the amount of unspent state funds appropriated for Act 167 related purposes that remain available for the agency's Act 167 efforts. There will be monthly reporting on or before the first day of each month beginning August 1st of 25 to the Health Reform Oversight Committee and Joint Fiscal Committee when legislature is not in session, House Healthcare and Senate Health and Welfare when they are, with updates on each of those items. Section 11C has some incentive money in it to encourage hospitals to engage proactively, think expansively, and propose transformation initiatives. It allows the agency to award grants to hospitals in state fiscal year 2026 that actively participate in healthcare transformation efforts to assist them in building partnerships, reducing hospital costs for hospital fiscal year 2026, and expanding Vermonters' access to healthcare services, including those delivered using telehealth. This has some money in it, but I think we're going to be looking at some additional money pieces separately. So notwithstanding any provision of 32 VSA 1031, which is the Health IT Fund, to the contrary, this appropriates $2 million from the fund to the agency in fiscal year 26 for grants to hospitals for collaborative efforts to reduce hospital costs in accordance with subsection A and with section 11A, and expand access to healthcare services, such as by enhancing telehealth infrastructure development. And it provides legislative intent that these funds should be awarded on a first come, first served basis until all of the funds have been distributed. Requires the agency to report by November 15th to the Health Reform Oversight Committee and Joint Fiscal Committee about how much of that $2 was obligated as of the 1st of November and how much had already been dispersed as of that date. Section 11D requires by November 1st, 2025, the Department of Financial Regulation provide the Health Reform Oversight Committee with a plan for preserving the sustainability of domestic health insurers in Vermont. which may include utilizing reinsurance. There is one domestic health insurer in Vermont, that is Blue Cross Blue Shield of Vermont. Let's be clear. Almost done. Section 12, retaining accountable care organization capabilities. As many of you probably know, the big accountable care organization that was participating in Medicaid and commercial payment reform pilots and models, is closing up its business at the end of the year. This directs the Agency of Human Services to explore opportunities to retain capabilities that were developed by or on behalf of an ACO that were funded in whole or in part using state or federal monies or both, and have the potential to be beneficial in the future, like capabilities related to comprehensive payment reform and quality data measurement and reporting. And the agency would report its findings and recommendations to the Health Reform Oversight Committee by November 1st. Section 13 is deleted. I've kept the numbering to align with the Senate version, if we can compare them side by side. Section 14, we're getting into some reporting now. By February 15th, 2026, the Green Mountain Care Board would provide an update to House Health Care and Senate Health and Welfare regarding the board's implementation of this act, including the status of its efforts to begin reference-based pricing and the effects of those efforts and activities on increasing access, to care, improving quality of care, and reducing cost of care in Vermont. But also have the board report on the potential future use of global hospital budgets, including various information about what it would look like and the pros and cons. Section 15 creates an annual report requirement for the Agency of Human Services. By February 15th annually, they would provide an update to House Health Care and Senate Health and Welfare on the status of the agency's efforts to develop, update, and implement the statewide healthcare delivery strategic plan. It would have the agency adopt an evaluation framework using an evidence-based approach to assess both the effectiveness of plan development and implementation and the plan's overall impact. Talks a little bit more about what that would look like, and how to have the agency include updated evaluation results annually as part of its report. But also have the agency report the activities of the Healthcare Delivery Advisory Committee during the previous year and the effects of the plan, the advisory committee, and other efforts and activities that the agency directed or engaged in on increasing access, improving quality, and reducing costs. Section 16 adds to the Green Mountain Care Board's existing annual report requirement that they include in their annual report the status of their efforts on reference-based pricing and any consideration about the future use of global hospital budgets and the effects on increasing access, improving quality of care, and reducing costs. Finally, effective dates. Almost everything is effective on passage except that updated version of the Green Mountain Care Board annual report will take effect on July 1st, 2026, because we already have a specific report for them for January of 2026. So this will be for the following year. And the vote out of committee was 8-3.
I know we'll have an amendment, but are there, because the reason we're having an amendment is because I'm seeing a look, is that originally a lot of this money was incorporated into the words of the budget language itself. And we took it out of the budget language and accounted for it and fenced it off. So the money is there for this bill, but the money is only there if the bill passes all the way through. If it doesn't, that money drops to the bottom line. So I'm just hoping I mentioned that on the floor today. It's not the only bill. All the bills are done that way this year. That was what made Rep. Donahue very happy because it was very clear what was being fenced off. So
I felt very special when you said.
So I don't want people who've worked so hard on this to worry about that. Are there questions? Dave and then Wayne?
Two, if I may.
Sure.
The reference-based pricing, what was the testimony from the Green Mountain Care Board as to the number of staff that were needed to implement that? Do you recall?
I believe, so that will be in the amendment that you are looking at. There are a couple of positions created. I think there are 2 specifically for reference-based pricing and 1 that may also work on that and have other duties.
Is that what they asked for?
I believe they asked they asked initially for more positions than that.
Somebody, apparently, John, you have the answer?
Yeah, well, there
if I
were,
may.
Go
well,
ahead.
there was 3 recommended by the governor. We supported that. Just falling back here, and then they were looking at the specific positions for the head model, and then 3 others.
Right.
So it ended up being 5 additional.
Right, so I think the initial request was 8, but I will look,
Yeah.
including the 3 from the governor and the governor's
And
recommend.
3 from the
I
governor.
guess what I'm trying to find out is, I understand the head is behind or whatever, but,
We're not sure.
sorry, a bad joke. If somebody comes in and testifies and says, we need X positions to do this function, I just want to find out if they were granted or not. Because,
So can we defer to the representative of the Green Mountain Fair Board to speak to their familiar with her?
Would you like to introduce yourself for the record, ma'am?
My pleasure. For the record, Diane Lanford, Green Mountain Care Board. The Green Mountain Care Board did testify in favor of this bill and has worked in the Senate and in the House healthcare committees to try to keep established positions with the work that's within the bill and work with Joint Fiscal Committee along the way. I know that originally when this bill passed the Senate, House and healthcare, there was 5 positions for this bill that we had. And in the course of constraints going forward, even in speaking with the Senate Appropriations Committee, we've come down to 3 that are in this bill, for this bill. And I think your JFO will walk through the exact positions that are in there. What you probably would want to know what happened to the other 2 and what they were for. Because global budgeting was a consideration here, but it's something that will probably happen after the establishment of the reference-based pricing. Those were the 2 positions for global budgeting that could wait until another day.
so, I didn't mean to cut you off, I'm sorry. So your position is the positions are adequate in this proposal?
We
do
believe
the
that they're
work.
adequate to do the work unless we miss something. And I've been saying with a caveat, we may be coming back next year with something unforeseen,
Okay.
brand new work that has not been, I think if I have a chance, the date of being able to get reference-based pricing is done as soon as applicable,
Practicable.
practicable. But no later than 2027. Okay, but that might be the date, the 2027, after we get into this and get some contracting, depending on how fast we can hire and establish the methodology, figure out the methodology, create the rules, go to LCAR. This is going to take a little bit of time, and we need to get this right because it's a very big deal.
Thank you. My second question, if I can continue. Do you know if there's a hospital that's currently trying to decide whether to close its birthing center? The people who go to that birthing center will still have their babies. The cost won't go away. They'll just go to different hospitals. Does the Green Mountain Care Board have, or does this bill in any way reduce their authority to say, we're going to give you an exception, but we're going to have to reduce some other budgets to stay within our global target of whatever the rate of growth is? Does this bill
I don't
change
believe this
anything?
modifies their authority around setting budgets that, how they implement within the caps that they set is not changed here because we don't tell
So
them.
they still have
how
the
to
same
set-
latitude?
I believe so. We don't tell them how or whether to set a system-wide, plan or target. That is something they do as their practice.
And I'm just trying to get a different issue, but when we try to suppress the costs at one hospital, we're likely to be increasing them at another hospital, and sometimes at an even higher rate. And I just wanted to try to wrap my head around that.
So I don't know if reference-based pricing helps that in any way, or if you have another response, Jen.
I think, there's a lot of work going on around hospital transformation and where there should be services and how to reduce duplications and address gaps. And I think that is part of what a lot of that work is looking at is what our healthcare system should look like in the future. I know you all worked on had a bill that was just signed, I think, 2 days ago, that allows for the establishment of freestanding birth centers. So there may, there may be another option soon for where people choose.
And this discussion might carry out in the strategic plan.
Might carry, yes, exactly,
What is
that's
our
right.
strategic
And that's
plan
part of what they're
around
looking
different
at.
services?
Exactly, is what is the distribution of services?
Thank you.
Yes, and what do we want?
Thank you.
I think there's a lot of interest in figuring out what people want the system to, the Vermont's healthcare system to look like. Some intentionality around that.
Thank you.
It's sort of like education, right? I mean, it's
It's
another topic.
similar, isn't it?
When-
Yeah, thank you. As I read through the bill, we have what we call an HRAP, Health
Yep.
Resource Allocation. Okay. First of all, there's a whole lot of new committees and organizations, boards, or whatever you want to call them, who have been established. I mean, I think about 4 or 5 of them.
In here, I think there's 2,
Well, I got the strategic,
and then there's a plan. There's an advisory committee and a primary care steering committee.
right. I didn't write them all. I probably did write them
And then
all
there's a
down.
long list of what goes into the plan.
Yes, yes. The Healthcare Delivery Advisory Committee, the Comprehensive Primary Healthcare Steering Committee.
Yes.
Oh, there's a Health Data Board. I assume that's different than Vital.
So there's a health information exchange steering committee that exists now. It has for a number of years.
Okay,
Yeah, so that's not.
okay, so that's already here. Okay. But the statewide healthcare delivery strategic plan,
Yes.
that's new.
Yes.
And that is different from HRAP.
It is, we have incorporated some, I think in-house healthcare, beyond what the Senate had done. They incorporated some elements of it and also direct that it be one of the sources that is consulted, that is referred to in developing the plan. I think there's potential that you will, if you all pass this, you will be revisiting the need for the plan or the role of the plan, the HRAP in the future.
Okay, will HRAP go away?
It, not based on this, because nothing's happened yet, but once this plan is established, or once you have seen the direction it's going, you all may choose to. I know that's a topic that is on the radar of the House Healthcare Committee.
Okay, so then we have the Health Data Board. I don't know what the full name of it is. It was
The Health Information Exchange Steering Committee?
Yes.
Yes.
Yes. That's different than Vital, which of course
Yes.
deals with buying software, instituting.
Right, so Vital operates the State's Health Information Exchange. The steering committee develops a lot of the policy around what that looks like, how, and makes recommendations on the state health information technology plan. They operate the statewide health information, or the statewide health information steering committee operates out of the Agency of Human Services.
Okay, that's a name. So that already exists.
It already exists.
So that's another one. Then the health spending reductions, is that just what we're trying to do, or is that an actual committee?
No, that's just something
We're trying to
the
do.
bill is trying to do a lot of health spending.
And just a lot of these things. The question I have is, sometimes simple is better. How many of these things are they've all got boards, 16, 19, 10, whatever. I mean, we're a small state. and
I'm
we
going to
don't-
defer that question to the committee. I just write what they tell me.
I'm just looking at the structure here that we're creating. I don't know if it's a bureaucracy. I mean, who was reporting to whom? And we've taken, it used to be Bishka. David and I had the honor of serving on Public Oversight Commission under Bishka. And then they broke Bishka up and it became DFR and Fremont Care Board. And now we're putting them back together again.
No, I don't think.
They're working with each other to go and.
They do that now.
Yes.
Have to do that now.
Okay.
Right, because health
That's not
insurance is
true.
still, other than rates, health insurance is still regulated out of DFR.
The rates are DFR, but all the.
No, the
others-
rates are at the premiums for major medical health insurance only are at the Green Mountain Care Board. All other
Insurances.
premiums and health and regulation of insurers and determination of health insurer solvency and all of that is still at
Yeah,
DFR.
that's an insurance thing, yeah, but the actual health insurance that we all encounter is done at Green Mountain Care Board, right? The premiums and,
The premiums are.
yes.
Just the premiums.
So they're going to try to figure out a way now to go and find out if all of these changes are going to lower our insurance premiums. What that says?
That's part of, yes, certainly part of it is looking at the impact of,
Thing.
right, impact of certain reductions on health insurance premiums. And so there's a role in that for the Green Mountain Care Board, but there's also a role both for non-major medical and for looking at insurer solvency for DFR. And so
Yeah.
that's why, and they collaborate frequently.
Okay, okay, good to understand that, but I'm just sort of looking at it's like, we just seem to be establishing more committees to do more things that are all sort of, I'm not sure how this all works.
Well, we can talk about that. What I'm hearing, and John, I see your hand raised. What
And I
I'm
do
hearing,
want
and
to,
Wayne.
yes, I remember.
Wayne
remember.
first.
Okay,
And then, but what I'm hearing in this bill, and I am no means a healthcare expert, is I'm hearing an attempt at more transparency and more accountability and reducing the costs of the healthcare system in Vermont. This is the only bill that we have seen this year that is attempting to do those things, as far as I know. So that's coming to us. That's my high level comment. Wayne and then John.
Got a couple just little simple questions, maybe John did the same, but the board, he says the board shall establish a budget. Does the board build the budget? Does it establish a budget? Does
You're
it
looking at the hospital,
approve the budget?
so the board, makes a budget order. I don't know this, actually, I don't know the specific details of what the whole process looks like, but a hospital comes in with a bunch of information in its proposed budget, and the board looks at it and makes a final budget order that is what the hospital's budget will be for the year.
So does the hospital actually create the budget, or they're the ones that would know all the different
So
elements?
John, I think has some
I can
comments on this. Go ahead, John.
Great, because I don't do that
Keep
part.
it simple here. So, every hospital right now is in the process of building their budget here for the next fiscal year, which begins October 1. And so we have a date by which we need to, submit that. And so our CFO, other people in leadership, they put the budget together that comes before the Board of Trustees, that has to be approved by the Board of Trustees by a certain date. I'm chair of the board of our trustee group, so I sign it here as representative of the board here. That gets submitted to Green Mountain Care Board for their review and establish what it's going to look like, whether as is or something isn't quite within the parameters of what they set for increases in expenses and patient revenue.
So I'm just, the word approved would be better than established in this case.
I don't know.
This is existing law. This is existing.
The other question is, in one place you mentioned federal and state antitrust laws. Just in general, is how could we in any way run afoul of federal or state antitrust law?
So one of the provisions in section 11A is looking at getting the hospitals and other healthcare providers together to come up with ways to reduce their budgets. Anytime you have a number of members of an industry come together, there's the potential for collusion, and it raises anti-competition, antitrust concerns. And so under established case law, there is state action immunity that says it's okay for them all to get together as long as the state is actively supervising. So that language is directing the Agency of Human Services to make sure they are actively supervising these conversations, and particularly what comes out of them, to make sure there is no antitrust issue.
So that agency would provide legal counsel.
They wouldn't be providing legal counsel. I'm sure their legal counsel would be advising the people who are doing the supervising. But yes, I don't believe they'd be providing legal counsel to the hospital.
John, you had some other questions too, yes?
Actually, no, I don't.
Okay.
Yeah.
Dave,
All
to
right.
you.
It really is, I don't know if this is a question, but Dr. Elliot Fisher's report to our healthcare committee indicated that there were some 269,000 visits to the ER. And that roughly 60% of them were avoidable.
Mhm.
And primarily, they're avoidable because of the primary care physician problem we have. So I'm just sitting here as a layperson saying, ooh, can the governor say do something about that? Can the Green Mountain Care Board say do something about that? Can the Agency of Human Services say do something? Or should this bill be saying that? Maybe it does and I missed it.
I think the bill has a fair amount in it about, I mean, part of the reason for creating the primary healthcare steering committee is to have primary care providers being involved in developing ways to increase the primary care workforce, to try to move care to that setting. It's challenging because if people don't want to practice primary care, we can't make them.
Well, I wonder. No.
Some of the ideas in the bill around, using reference-based pricing, once it gets going, to incentivize primary care and increase reimbursement rates for primary care.
I just feel we're in a crisis.
That's right. So one of the
And when
things,
you're in a crisis, it's, I form little committees, et cetera. So I'm just trying to see what's actionable. So forgive me, it's not really a
we're
question.
also trying to pay the current primary care and FQHCs, we're trying to make sure that they're getting paid. And some of that was in the budget.
Yep.
In addition to the money that we put in, if it turns out to be matchable, we have set aside money for primary care residency, rural residency. That's at Gifford and with Lamoille. Somebody will remember.
Maple, yeah.
Maple Mountain.
Maple Mountain. Yes, but it's something at Gifford and something with Lamoille Partners or,
Yes.
anyway. So that would,
Thank
we
you.
are addressing where we can, I
Yes.
believe.
And you have created scholarship programs and loan repayment and.
Right, so, and just like housing and education, we never have enough money, right? John,
So I don't have a question. I was going to say something.
Okay.
A little bit in response to what you were asking about creating more advisory groups and that kind of thing.
Bureaucracy.
Bureaucracy. I don't think that's the intent of these two new groups here. I think it's really kind of help move some transformation forward here. To best match where we are here today, to be clear about what we're trying to provide here. So that's how I kind of read that. When I looked at that, I was like, okay, two more groups of like 19 people, 19 representation, 19 different organizations here. I think we've got to thought about this here for a long time here. I think a lot of that is needed for right now. I don't think these advisory groups are going to be here in perpetuity here, which is a long time, right? We talked about that earlier tonight, right?
it's a very long time, it's
A long time. So I do think that's the intent of this right here. So that's what I wanted to say.
okay. Yes,
I just want to say that we can create more primary care, but that doesn't mean we can get people to use more primary care. Some of those 230,000 people or whatever, they're going into ERs, they're going there. In some cases, they're frequent flyers, as they call it, and they go 80 times in a month. I mean, some of them may have mental health issues, they have other issues. There are things that we cannot, the hospital has to accept and see these people by federal law. They can't just, I'm sorry, go away, I'm not going to treat you. So it's a situation though, which we may not be able to control 100% by any legislation, number one.
no, that's right.
I just wonder, maybe someone from the committee can answer
Well,
this.
we have, Chair Black would like to
Yes.
address, address this question. So would you introduce yourself, Chair Black? And
So, Representative Elizabeth Black, Chair of Health Healthcare. First of all, I want to acknowledge and echo your concerns about creating new steering committees. I shuddered when I will tell you, I personally am the one that inserted the language for primary care. Because of a lot of the frustrations that Representative Iacoboni talked about. And I did want to address, how we actually, we put money into things like scholarships or loan repayments. But what we don't do, no matter what we do, we still have not enough primary care. And the fundamental reason we do not have enough is because we pay primary care less money. And, reference-based pricing, people think, oh, well, we'll just set the reference to Medicare and everybody gets this amount. But that's kind of the beauty of reference-based pricing, is that you can use it as a tool to pull different levers. Which means you can say, we're going to pay primary care this amount of Medicare. We're going to pay this type of care a different amount. So you can incentivize and increase payments. And, you know, the emergency department issue, which is one of the largest, and I mean, Blue Cross Blue Shield sitting next to you, one of the largest outpatient hospital costs other than pharmaceuticals is emergency departments. And I think, I mean, I looked at our list of witnesses and it's 2 pages long. I'm gonna have to pull appropriations of, it's on my desk if anyone wants to look at it. But every single provider that came into us and from some sort of primary care organization, and there were lots. I went onto their website as they were testifying, and none of them had weekend or evening hours. And the reason that they do not have weekend or evening hours is because they cannot afford to staff their facilities. And so when people call after 4 p.m. with something that is not an emergency, but that should be seen, they are sent to the emergency department. So, no, there are things in this bill that try to right that. If we can encourage and induce an investment in primary care, then primary care will come back to providing a majority of people's care so that they won't be going to the more expensive places. It's not, you know, you're always going to have that issue. I think you refer to frequent flyers. You're always gonna have that issue. But if you go to any emergency department right now at all of our hospitals, you go and you see their waiting rooms. And I know that you cannot always see what's going on in people, but you will see examples of things that can be delivered in a much lower cost environment, the right care, the right place, at the right time. And really, this bill can do that.
How does it do that?
Well, it does that with establishing reference-based pricing. Will give the Rehab Care Board the authority to start changing the levers of what type of, the one thing that you find out when you delve into healthcare long enough is that the amount of money that we pay for services doesn't really have anything to do with the service that we're paying for. It has to do with another service that is a loss leader. We make money in some areas so that we can subsidize others. Yes. Reference-based pricing is a tool that can be used to right size and to pay for the services that, for what the value of those services actually are. And by doing that, you can start to see that the system becomes much more efficient and less costly, frankly, by ensuring that Vermonters are receiving the care when they need it in the right place. And it does do that. And as someone who created this whole primary care, I do realize there are other groups. I looked at all of them.
Yeah.
I really wanted to make a very, very centric, only primary care, and we talked about Dr. Elliott Fisher. Really wanted to make it a comprehensive, powerful group with a strong voice that had a seat at the table that had to be worked with in collaboration. Because I think when you look at some of the other groups that have been established, they're more sort of advisories and, you know, they sort of input information and that information goes nowhere. I wanted to primary care.
Thank you.
Sorry.
Thank you. No, it's fine. I know we could all talk about, we're getting into the policy a lot. I know Jen has a hard stop at 4 and we have an amendment. John, is there something else you?
No,
want
it's
to say?
okay. I can do it all.
Are you good? Okay. All right. All right. We do have an amendment.
Yes, you want to do the amendment and then
And
Nolan will
then
talk?
Nolan.
Okay.
Is that the right order to do that in? Okay. Nolan's nodding his head. Okay. He's looking at this.
Okay, so this is a potential amendment from this committee to deal with the money pieces. So this would do a couple of things. It would strike out section 11C, that's the piece that had the $2 million for incentive monies, and put it back in by moving them and move the money to a different part of the bill, so that all the appropriations would be in one section of the bill.
That's really helpful.
So I just basically took out subsection B that had the money in it, and I put in extra space, put in a new B that still has the agency reporting on how much was obligated as of November 1st, but it just refers to how much of the $2 million appropriated pursuant to section 18B, because that's where this money now lives. The second is by striking out the effective dates and putting in new sections, including effective dates. So section 17 would be Green Mountain Care Board positions. It authorizes 3 new permanent classified positions of the Green Mountain Care Board in FY26. 1 director, reference-based pricing, 1 project manager, reference-based pricing, and 1 operations, procurement, and contractual oversight manager. And has them transferred and converted from existing vacant positions in the executive branch.
That's going from the position pool, not creating new.
Section 18 is the appropriations. So we have 2.2 million from the general fund to the Agency of Human Services in FY26. 2 million of which is for feasibility analysis and transformation plan development with hospitals, designated agencies, primary care organizations, and other community-based providers. 100,000 for development of quality and access measures, targets, and monitoring strategies for the statewide healthcare delivery strategic plan, and 100,000 to support the development of alternative payment model. Here's where I moved that $2 million, so still notwithstanding any provision of the health IT fund statute to the contrary, $2 million goes to the Agency of Human Services for grants to hospitals, with references to the collaborative efforts in sections 11A and 11C, and expanding access, such as by enhancing telehealth infrastructure development. Subsection C is the appropriation to the Green Mountain Care Board. This is $1,062,500 in fiscal year 2026 for use as follows. $512,500 for the positions authorized in section 17. So we get a little more detail in subdivision 2. 500,000 from the general fund for contracts, including contracts for assistance with implementing reference-based pricing, and 50,000 from the general fund for contract with the Vermont Program for Quality in Healthcare to engage in quality initiatives in accordance with this act. Of the funds appropriated for the 3 positions, $205,000 comes from the general fund, and $307,500 is from the Green Mountain Care Board Regulatory and Administrative Fund. So this is the 40-60 bill back split. Then we also have another notwithstanding on the HIT fund, and this appropriates $150,000 from the fund to the Green Mountain Care Board in FY26 for expenses associated with increased standardization of electronic hospital budget data submissions in accordance with section 4. And then we have a new effective date section that has not just the change to the Green Mountain Care Board annual report section, section 16, but also the positions and appropriations taking effect on July 1st, 2026. Everything else takes effect on passage.
Great. Thank you. And if you don't mind staying, we'll have Nolan come up and talk about the fiscal note. Again, we're not voting on any of this today. I'll let you know when we're voting on. Welcome to end of session. So Nolan's fiscal notes on our website.
For the record, Noel Reynolds, Joint Fiscal Office. Would you like to see the fiscal note for the bill as passed House Healthcare, or would you like to see a chart that I made for what will be the fiscal note for this committee as it passes the committee, which is not posted yet?
Yes, we would like the second one, please.
Okay.
Everybody can look at the other one.
Not anywhere yet because I
Updated charts.
couldn't post something that hadn't been presented yet. And so, nor do I have a fiscal note for a bill that hasn't passed by the committee. But I have a chart that I put together.
Charts are different than fiscal notes,
Exactly. So this I can do, and I can also,
technical terms.
and I can also have Aaron post it. Let me pull this up.
This is different from the chart that's in the fiscal note that's been
Correct.
posted. Okay.
Correct. And the reason is because I've shortened it up a little bit, but also this has the bill back.
Okay,
That's
great.
the major difference, is that it was general fund as it came out of House
Right.
Healthcare, and then in the appropriations big bill process, we determined that bill back, we could use bill back
Right.
for the positions.
Thus saving some general
So
stuff, which we,
general funds,
can you make that bigger?
yes.
Yes.
Okay. I was gonna joke around and make it smaller, but that's not a good joke. As I am now over 50 and I'm like,
Okay.
all right. So I won't run through the details, but I'm just sort of, because generated head, but you can see there's $2.2 million of general fund for the Green Mountain Care, sorry, for AHS. Then there's the $2 million from the HIT fund. These are the grants to hospitals for a collaborative effort to reduce hospital costs. This was added by the House Healthcare Committee. It was not in the Senate bill.
And HIT is?
The Health Information Technology Fund. And people have questions about that. I can do an aside on that and where that comes
Yes, that would be a
from.
side conversation
I'm
and.
happy to get there after, and how is it raised? Where's the money come from? How much is left in the fund if we do this, et cetera? I can answer all those questions.
Okay. See no one with questions.
Yes, unless people ask them here, then I would happily do. So it's a total of $4.2 million between general fund and health information technology fund dollars that would go to AHS. On the Green Mountain Care Board side, we have 2.9, so basically almost $3 million. That would be general fund.
That's not the Green Mountain Care Board, that's the total.
I'm sorry, yes, thank you. 755,000 for general fund. We have another 150,000 for the HIT fund, 307,500 from bill back for a total of 1.2. So, and then the bottom shows you, by the way, just to jump back up positions, you can see the way the bill back works is the 40-60 split. The state covers 40%, and then the other 60%, the Green Mountain Care Board DFR has a similar authority. They bill the providers in the health insurance, basically the entities for which they regulate, they can bill them for the regulating of those services. So the 60% of that can come out of the bill back function, and that's 307,500. So for total, the bill has 2.955 million in general fund, 2.15 million in HIT funds, 307,500 in bill back, and then for a total across all funds of $5.4 million. And this is posted now, so you can, we should have it up there.
And the incentive, excuse me,
Okay.
the incentive funds,
Mhm.
those are paid with general fund
That's the health information,
or HIT?
which, about the grants to hospital? Which one are you talking about? Oh,
2 million in incentive, was that? Did I get the number right?
That's the HIT fund.
talking about the HIT, the grants to hospitals.
Okay,
I didn't see those as incentive, I saw it as.
I think that's the word that we use, right?
Oh, okay, sorry, that's not how I have it listed here, but yes, that's from the health information technology.
Okay,
And that's an acceptable use of the HIT fund.
Yes, and you cannot withstand. It's a state law, so.
You always notwithstand.
But it seems that it is, maybe I'll turn to Jen on this, but I think it was determined it's germane if it's used. I think there was telehealth with some of the language that was
Yeah, they're
used.
not specifically terminated. I mean, this is based on funds from the health insurance claims tax.
And I can get into the weeds on where that comes
As
from.
long as you're, as long as you're using it for health related purposes, I think you're probably on pretty solid track.
Well, it's nice that we don't have to use general fund for that. That's a good thing. So are there any questions for Nolan?
Oh.
And so this was all reserved in the budget, fenced off, not, we extracted all the S126 pieces that were in the budget itself and put it all back with the bill. So that's what our amendment does. But the money has been accounted for. So as I said this morning, or this afternoon, it feels like this morning.
The other thing I could also flag real quick too, is that the House did reduce the cost of the bill from what the Senate had.
Yes.
So,
Well, that's in the other chart on the other fiscal note, is that correct?
well, the other fiscal note would have what the Senate did. This has what the House will do, but I have another chart that can show you the difference between the two. If anyone wants to see it.
Sure.
Okay,
Okay.
we'll go for it.
Well,
We'll go
it's gonna
for
be
it.
right now, but
Somebody
I don't think
in
we-
the conference
then we'll-
committee.
Then we'll wrap up. Yeah, okay.
Just,
And you give that to
this
Aaron?
would be.
I can post it, sure.
Yeah.
For you, of course. All right, I'll send it there.
A lot has gone into this.
Yes,
I can see that.
yes. It has been
Very
the
good.
hard work of many people. A number of our bills this year.
So this is the difference between the as passed the Senate, as passed House healthcare, not the amendment. So
Please.
Right, this is not, yeah. Thank you, House Healthcare, for giving a few bucks off. We always appreciate that.
So you can see that, and so the far right column is different than general funds and the different than HIT funds. And so you can see that they took $250,000 off transformation work and HHS, knocked 25,000 off development for quality measures, another 25,000 off development of alternative payment models, but then added 2 million on the HIT fund. And then you can see the other difference was House Healthcare added appropriations for a Vermont program for quality and healthcare contract. So there was work in the Senate bill for VPQ, and VPQ HCs came out, was like, we're happy to be part of it, but we need an appropriation. So the House Healthcare Committee gave that to them. So you can see it's a down of 300 and up of 50 in general fund. So it's a total of $250,000 less in general fund, but then 2 million in HIT fund.
Great. Thank you very much. Anybody else have any more questions at this point? Thank you all guests for joining us for this and being available if we had questions. Jen and Nolan, thank you. Committee, as I said, I think earlier, we are not going to vote on this bill today. I don't know if we're voting on it tomorrow or not. We'll find out. Right now, our committee page has a lot of TBD on it. Tomorrow, we have now learned when we were on the floor that there's going to be a caucus of the whole about the housing bill. As soon as we adjourn, we will gavel in and then recess for that. And so I don't know what's going to happen after that. I don't know how long that's going to be. After we get through that, I'm imagining I will get some direction on both of these bills. So keep your phones nearby. We'll text you any updates and see where it is. So I can't tell you whether tomorrow is going to be a long or a short day, but today we will get you out before the Corporate Cup Challenge so you can drive out safely. So all of those who are worried about that will be able to get out. And so we'll be back in committee at a point to be determined tomorrow. Thank you all for your hard work.